This is The Healthy Healer, where true voice is your medicine. This is where we help doctors and other healers navigate through the challenging times by learning from the best minds in the healing industry. Laugh, cry, and be surprised. It's entertainment, education, and inspiration so you can continue to be the unique and amazing healer you were destined to be. Welcome to humanity. Welcome to The Healthy Healer with Dr. Fred.
Hello, everyone. Welcome to The Healthy Healer. Today, I have the guest that I've been looking for a few weeks. When Daniel Gospodarek applied for becoming a guest on my show, both me and my assistants were very excited to have him here. The storyline here is sort of like exactly what we're looking for when we're looking for a healthy healer. Someone who's been through their own set of traumas or their own set of challenges, and has decided to transmute that into being someone who makes a difference for other people. Clearly, Daniel's story does align with that, and I can't wait to introduce him to you. This will be the first time that I actually spoke with Daniel, but I'm just as excited as any of you to hear what he has to say. So first of all, Daniel, welcome to The Healthy Healer. It's just a wonderful opportunity to have you on the show. Thank you.
Thank you for having me, Dr. Fred. I'm excited to share my story and just kind of touch listeners' lives, especially if they're influenced or touched by TBIs or traumatic brain injuries in their lives.
Okay, great. So that's what you're going to use. It sounds like at least it's an important jumping off point. Was in high school, Daniel had a traumatic event that eventually resulted in what he just said, a TBI or a traumatic brain injury. Daniel, I like to ask my guests this simple question, and maybe this will lead to you talking about your life even before the TBI, or it may start with the TBI. And the simple question is a 9-letter question. It's only 9 letters. And that question is, Daniel Gospodarek, who are you? Tell us. Yeah.
So currently, I'm a mental health therapist, licensed clinical social worker, and also a person in TBI recovery. There's a lot of other details that can go in there. A family man, son, brother, nephew, cousin. So all those labels apply. But right now I'm just trying to use that TBI history that I've experienced and, not only hit TBIs and support that population, but also people who have mental illnesses. So often they very much mirror each other. So
I'm very excited to hear about that. Tell us a little bit more about what you're noticing, because I know that you work in psychiatric facilities. What are you noticing about the mirroring relationship between TBI survivors and people with significant psychiatric problems?
So they're highly correlated. With the hospital I work at is one of the 2 safety nets for the state of Colorado. So we really see a lot of people who have exhausted their public-private benefits that need long-term psych stabilization, and the pieces that go with that: homelessness, incarceration, years of psychiatric medications or engagement in treatment on some level. So really, illnesses or symptoms onset before a TBI, or the TBI and then onset of symptoms maybe later. So it just depends. But definitely being in some of those institutions, incarcerated, homelessness really puts you at higher levels of TBI risk.
So when you're in those homes, you're at high risk, or were you at high risk? Was it likely that you had a TBI that might have led or contributed to what is now being called a psychiatric illness, or both?
I think it's both.
Okay.
I don't know the hard research on which one always comes first. But
right.
We all know the ACE study, or most of us know the ACE study by Kaiser Permanente, adverse childhood experiences, right? So a lot of people have high ACE scores, and that then puts you at risk for increased psychiatric symptoms later in life, or substance use, and consuming a lot of alcohol puts you at a higher risk of falling. Falling is one of the big keys for TBIs too.
Right.
So,
okay. So you're noticing
out a little bit. Sorry, go ahead.
Yeah, no problem. So you're noticing that you know, that a high ACE score or can lead to poor judgment or increased substance abuse, which leads to an unsteadiness in life or an unsteadiness in a physical capacity, an impossible fall, or making poor decisions, getting yourself into maybe something that you later would call an accident, or something where you get traumatized to the point where a traumatic brain injury becomes possible, and then either contributes directly to a predisposition for psychiatric illness, or in some cases actually is the precursor for a later diagnosis of psychiatric illness. Is that fair to say?
Yeah, that's correct.
Okay. So tell me what you're learning. What is your role in the hospital at this point?
So I am a licensed clinical social worker working in an incompetent to proceed unit right now. So that is folks wrapped up in the criminal justice system, as well as been deemed incompetent to proceed due to mental illness. So our part is both psych as well as restoration right now. But I also have my private practice that really hones in on that TBI mental illness population that's in the community, right? And maybe needs access to resources, or maybe somebody, some therapists don't always understand the interplay between TBIs and mental illness. And, or I'm sure there are other therapists, I'm not the only one, but just being able to sit with that. Sometimes clients don't find that other people are able to sit with both.
Okay, beautiful. So let me ask you a few questions about TBI. You use the term as if it actually has a major definition. And what I really want to know about is, like, is TBI have a broad definition? Can you get a TBI, for instance, from status post-acute meningitis as just as well as getting hit in the head with a bat? Are they both TBIs? Or tell me more.
So from my experience, it depends on where you're at in the world. So some are acquired or non-acquired. Some are, I forget the other phrases offhand, but like a puncture and a non-puncture. So it just depends. You have your blows to the head, auto accidents, falls, sports, violence, gunshots. Then you have the internal too, right? Meningitis, other bacterial infections that can cross that blood-brain barrier, but still do a lot of injury inside the brain once they're there. So, it can stem from external, it can stem from internal.
Okay. And is it important to know, like, for instance, I wonder if someone is like been in a lot of fights, or someone's been bopped around a bunch of times, is that a different kind of TBI than one would get if they were in a car accident or had meningitis? Can it be diagnosed? Can you get an idea that the TBI itself has a different quality based on its source that caused it?
I think the difference in TBI and that level would be rated like that, low, mild, moderate, high, or severe in terms of impact on functioning. But to say, somebody that has 7 concussions from boxing or football is impacted less or more than somebody who was, had a car accident and had maybe needed a craniotomy or something like that, or had a slight brain bleed. It's going to depend on the person, because everyone's so unique and how a TBI will impact them, as well as the TBI itself. 2 people can have a very similar TBI, but have very different changes in functioning.
Understood. All right. So let's take another deeper look at this. So the idea is that, the I in TBI, the injury itself, when does that actually cross the line and become a TBI? So I get hit in the head with a bat and it hurts, let's say, or I get, let's make it a little less gruesome. Let's say I'm just at the plate and I get hit in the head with a pitched ball. And so, it hurts. And when is it stated that I now have a injury that is sourced by a traumatic, by a traumatic event? What has to happen in order for it to be called a true TBI?
So typically some sort of assessment related to a concussion on that level.
Okay.
Right. And then, they consider concussions now mild or moderate TBIs, depending on the severity.
Okay. So is that neuropsychological testing that does that type of assessment, or who does it?
It would probably most likely be a neurologist or, a doctor at the emergency room if somebody were to go visit them.
Okay. And does it have to include cognitive deficits, or can it, or not? I mean, if I'm just physical, is that also a TBI?
Physical in what way?
Meaning, let's say I have, some sort of, let's say, an anoxia that makes one of my limbs less likely than, less workable than the other limb, or something like my lower leg or something.
So I think, are you asking if that could still be a TBI, or does it only
a TBI, or does TBI almost always include cognitive deficits as well, cognitive changes?
I don't think so.
Okay.
I think TBI is very encompassing, right? Because if you injure the part of your brain where, you're unable to send, neuro messages or signals to move your pinky finger, right? That is some sort of injury there.
Right. So what's the difference between, let's say, a hemorrhagic stroke versus a TBI versus, let's say, an anoxic brain injury? So all of those things would lead to deficits. And I guess then we're looking at the T in TBI, aren't we?
Right. And this is getting outside of my scope too. So
okay. Sorry about that.
No, it's okay. So this is more like neuropsych or neurology. So I can answer it, but we could just cut it out too.
All right. So let's just take a look at that. We'll take a look at what it really means. Is it, basically we're talking about injuries that are traumatically induced when we're talking about TBIs. And I think that's okay to look at that.
For sure.
Right. All right.
Well, I just needed to be transparent with you, and I'm not going to
that's fine. No, I think our listeners are going to appreciate that you recognize some limitations and boundaries where you're taken out of your scope. And that's totally reasonable. Very fair. I love that. Thank you for being there. So, some people, they just go off on a limb and just start guessing at answers. And even if it's clinical, that tends to really decrease the the credibility of the speaker. So it sounds like it's important for you to be truthful and honest with yourself and others. And I totally see that.
Definitely.
How do you treat someone with TBI once they're in the hospital, or once they show up at your office? What is it that you're doing that is different than maybe what an average therapist who isn't so familiar with TBI might never know how to do?
Right. So I would say TBIs are pretty niche in terms of the grief and loss that permeates so many different domains depending on somebody's functioning and how it's changed, right? From ability to focus, from ability to maybe even work a 40-hour-a-week job, or maybe they can work a 40-hour-a-week job, but they can't do the same job, right? So maybe you're looking at a change in socioeconomic status of some sort, right? Doing things typically after a TBI, it's not good to get hit in the head again. Typically, right? I mean, it's not good at any time to get hit in the head hard, but so if you're an avid snowboarder and no longer able to snowboard, right? So you're looking at hobby changes. You're also looking at maybe even social network changes, because if you can't hang out with people on the slopes anymore, right? These dynamics shift. So being able to have these grief and loss experiences, the shame, the guilt, the anger, whatever it is, right, around this is one part of, TBI specific stuff, but also the nuances around TBIs in terms of impulse control, challenges with sleep, headaches, family support, rage, right? All these different pieces come into play, whereas somebody could be like, oh, somebody's, impulsive, somebody is, very short or irritable, not sleeping, right? Maybe this is bipolar. And it's like, well, maybe there's a brain injury going on, right?
Right.
Let's talk about this first before we put a diagnosis on something.
So that's an interesting point too. The differential diagnosis between a TBI and other different otherwise, like if you didn't know there was a trauma, the psychiatrist or the trained clinician may actually diagnose somebody with a primary psychiatric condition if they overlook the notion that there may have been some degree of trauma that led to a brain injury, right?
Right.
So there's probably some people who are diagnosed with psychiatric illnesses who, as a primary condition, which in fact are TBI primarily. Is that right?
Right. And that, let's see, in the DSM-5, I don't believe there's a TBI diagnosis, but you would diagnose it. And this is where neuropsychological testing would come in and say, is this a mild cognitive impairment, moderate, right? And that would be your primary. And then there would be, qualifiers afterwards.
Right. Like secondary to a physical condition or some sort, or secondary to a traumatic event. I understood.
Right.
Okay. All right. So it sounds like you have a practice as well. You talked a little bit about your outpatient practice and your inpatient practice. How do these two things interface? And, what do you notice that you might do differently, or what nuances might work both for inpatients, people who are locked up behind closed doors and, incarcerated or in inpatient unit, and people who have the freedom to get to your office? What kind of things are either different or the same about the treatment of those people?
So I would say that everyone wants to be treated as a person, whether you're outpatient or inpatient, right? And that authenticity is really important.
Yeah.
Being able to sit with the difficult conversations when people are talking about how they sustain TBIs, how they, were incarcerated or what happened to them, right? Their traumas, and being able to sit with some of that intensity. That goes both directions. I would say it's different in the terms of there's much more freedom in terms of the outpatient work that I do, and a lot less structure, a lot less oversight. So, it's maybe 1 hour a day that's therapy a week versus, unit programming 6 hours a day or so.
Right.
So there's a lot more leeway outpatient, and that's where they would differ hugely. But go ahead.
No, please continue.
All the people in my private practice are private pay. And then also at the hospital, it's state funded. So that's a huge, division right there.
Right there. That is a huge division. And in your experience, tell us a little bit about your experience in high school. What happened to you? What led you to be so lit up about making sure that you treated these people for the rest of your life?
Yeah. So it happened July 2009. My neighbor and I in rural Wisconsin were driving, and we were slowing down for a stop sign, and the right side of the vehicle, both the right side tires went off the road. The driver corrected. I was the passenger, and we were in the oncoming lane, corrected again, and then we rolled 4 times. And that's all I remember. Next thing I know, I woke up in the ICU bed, but between those, 72 hours of being in a coma, a lot happened. So the driver who was still conscious was able to find our cell phones, called EMS, called his mom, who was a nurse as well. And she was like, hey, if you're going to take him to a rural hospital and he has a TBI, they're going to assess him and send him out. You might as well just take him directly. And they did. So that was probably something that saved my life right there. And then from that moment on, needed to have brain surgery. So I had brain bleed on my left temporal lobe, fractured my skull, collapsed lung, and then also I had a stroke in my left prefrontal lobe. So,
wow, amazing.
Yeah, they told my parents they weren't sure if I was going to make it through the night, but the next 72 hours, 24 hours would tell us a lot. So,
do you have any residuals at this point?
Not too much. When I stay up for, prolonged periods of time or can't get a good night's sleep, multiple days on the end, I'll notice like short-term memory. But it's very minimal. It's not like what it was, 3 months out from the accident.
Yeah.
So from there I did 10 days ICU, 7 days inpatient rehab, and then 3 months of physical therapy and 17 months of speech therapy.
Wow. Really amazing. That's amazing.
It was a long haul.
And when you got out and got done, is that when you knew that you would be someone who helped people who had had similar experiences?
So I knew in the hospital I would land somewhere in the helping profession, but it actually wasn't until I spoke to my sister, who's actually a social worker in Wisconsin.
Mm-hmm.
And she was like, check out this profession. I did. And then I ended up with my bachelor's. And then I worked for a year and a half or so. And then I decided that it wasn't the kind of work I wanted to be doing. And I needed to go back for my master's. So that's what I did.
Okay. Interesting.
Yeah.
Yeah. I just have to share, in case some of my listeners remember this, is that I was in an extremely similar car accident in 2010. I
Mm-hmm.
was the driver of the car, and it was on I-94, as a matter of fact. So you might be familiar with that road. And I was between um, Jackson, Michigan, and Detroit, Michigan, on a late Saturday night on the way home from Indiana. I was on my way from South Bend, Indiana, to Detroit, and I also went off the side of the road. I got hit from behind and with somebody going 90 miles an hour, and popped me again. And then I was off the road to the right. And when I tried to veer back, the same kind of thing happened. I wasn't in oncoming traffic, but somehow I got to where I got to, and I rolled 3 times into the woods to the
Mm-hmm.
side to the right. And I didn't have any, I fortunately walked away from that accident. I actually walked out of that car
Mm-hmm.
that didn't look anything like a car when I walked out of it,
Right.
and came up to the berm. And, that particular event was an event where I have three, I have 3 events in my life that are NDEs, near death experiences. And I include that one in that. And in
Mm-hmm.
those 7 seconds, we call it 7 seconds of when I was rolling it to the right there.
Yeah.
I had this conversation with God. And I don't know, I
Mm-hmm.
wonder if you had any experiences, or you talk to people who've had experiences of near death, who have conversations with their spiritual leader or a higher power. I, for one, had one, and I know what he said to me, which was, he was kind of disgusted with me, actually. And he said something like, I'm going to let you live. I'm going to let you live. Good. And I'm going to give you everything you want. Good luck with that. That's what he told me. So, yeah.
So I did not. The last thing I remember in that accident, from the moment the accident started, was the red, blue, and yellow circuits underneath the stereo.
Interesting.
And
Mm-hmm.
that's then I came to in the ICU 3 days later, and I thought I had gone through the time shift, and I thought I was in France.
Uh-huh. Uh-huh.
So it's just how my brain kind of processed it. But no, I didn't have anything like that. I know there was one time I was in the inpatient rehab, and going from a high level functioning 17-year-old and being knocked down to where you need 2 to 3 nurses to help you walk.
Right.
I mean, talk about like grief and loss and identity shifts, right? And I needed to get out of the bed, and I buzzed the nurse, and they weren't coming. So I just decided I was going to do it myself. And I don't know what it was, but I just felt like this like shimmer down the back of my spine. And I hadn't been able to stand up since before the accident on my own. And I just stood up by myself. And I
Wow.
knew that there was some higher power there,
I
like
see.
whatever it was giving me that strength, because I'd not been able to do that. And, that had to be like at least 14 days, 13 days, maybe.
Interesting. So have you noticed anything about people who are responding to the treatment, either getting better or getting worse, or during the trauma, associated with any kind of a higher power, or mystical experiences, or supernatural experiences?
I'm not noticing any like supernatural experiences that they are, so to speak, experiencing either in session or in between session. I I will say that in eye movement desensitization and reprocessing therapy, sometimes it can be beneficial if somebody is stuck, and just because of the assessments that we do, there's people are multidimensional, and culture, beliefs, religious beliefs, whatever they are very important to integrate into therapy. And sometimes it can be really beneficial if somebody's stuck in terms of reprocessing with EMDR, to say like, like, I wonder what your higher power would say here.
Yeah.
Right. And
yeah.
then like sometimes that will just ignite the reprocessing, and we'll go from there.
Mm-hmm.
So we definitely use it. I just don't see it all the time.
Mm-hmm. Interesting. Very interesting. And what kind of therapies do you use? You mentioned EMDR. Is that something that you yourself use, or do you count on the staff to do that, or what do you know? Are you trained in that as well?
I am. I'm in the middle of my certification process right now, and then starting somatic experiencing next month. But otherwise, I'm trained in cognitive behavioral therapy, acceptance and commitment therapy, and then EMDR.
Beautiful. All right, that's fantastic. And when do you work in nursing homes as well and rehab clinics? Do you get out there and there?
No, I do not. So I have my office, and then I do telehealth work outside of when I'm not in the office. And then otherwise, my other job is all in the hospital.
Okay. And when you mentioned that you do some work in the prison, is that, or the jails? Yes. Or is that more for telehealth?
It's all actually in the hospital, but they're court ordered from the jail to be inpatient psych.
I see. Okay. Yep. So the severely mentally ill, perhaps, or those who are been traumatized. Yeah.
Yeah.
Okay, great. And when you say, you mentioned that there's a huge mirror between, TBI and severe mentally ill, right?
Mm-hmm.
If you had something to say to people who, thought that their family member or someone they loved or was caring for must be sick, like they're acting weird, there's new changes, maybe they're not having as much motivation, or maybe they're saying things out of the top of their head, without much filter. What would you tell these people? How would you tell these people to consider the possibility that maybe this isn't primarily a psychiatric condition, but is in fact a possible traumatic-based circumstance?
Mm-hmm. Would you want me to come up with a question, or
like what would you want? Maybe what should our listeners do if they're thinking someone's sick and they're not yet diagnosed, and you've tweaked them to think that that maybe they had a traumatic brain injury at some point, or how should they check that out?
Sure. So I would be very curious around when the shifts in cognition functioning started, right? Any events or, traumas or anything, even if it was like a high school football game, right? Or a soccer game, something of that level. And then also get them to a trained professional that could do an assessment.
Okay.
And ask questions around timing of symptoms, correlations between symptoms. So that would be my suggestion of either a trained mental health clinician that knows TBIs, or a doctor of some sort.
Is it conceivable to actually get on the other side of a TBI without psychiatric care? Can you, let's say you have cognitive changes that are related to a trauma. Can you do therapy like without medicine and without hospitalization, institutionalization, and actually get someone on the other side of the experiences that they're having secondary to the traumatic brain injury?
So you're asking if the mental illness symptoms would always necessitate like inpatient hospitalization,
or some form of acute psychiatric intervention? Is it conceivable that could be done without acute psychiatric intervention?
Oh yes, 100%.
Okay.
I mean, even in my own case, I didn't go to therapy till 3 years after the TBI.
Mm-hmm.
So
okay.
And I went to school. So it was my junior going into senior year, that summer break. I was back in school at the end of August, even though it was July when the accident happened. So I mean, it was wild. Like I don't remember anything.
Yeah.
But then I went into undergrad.
Right. The next year.
Yeah. So I think a lot of that comes like, do all TBIs need mental health work? No.
Okay.
But if there are like, oh, I'm struggling, I'm noticing after that concussion or, whatever happened, an increase in alcohol use, right?
Right.
Or interpersonal issues with my partner.
Right.
Right. Those are some of those flags, right, that are saying, okay, what's starting to slip?
Okay. Very
and
good.
how do we address those?
And how do you address them as someone who does therapy with these people? What's the approach that you use?
Sure. So I think a lot of it is going to be wrapped up in that assessment and that rapport in the first few sessions, right? Figuring out A, areas that are needing support, B, how much guilt and shame, how much maybe remorse is in there for maybe even, impulsively yelling at their support system. Some of that can be targeted with EMDR, right? Some of the guilt and shame may be associated with a car accident, right? If you were the driver, right?
Right.
Can be targeted with EMDR as well. And then a lot of it is learning present moment skills, mindfulness, regulation skills of your emotions, right? Slowing that nervous system down.
Excellent. So some of the negative vibration experiences of guilt and shame and remorse, you've spoken to those a few times. What is it? How do you help somebody out of that? Like if they're feeling like, hey, I shouldn't have gotten into that car. I knew he was drinking, or I shouldn't have gotten behind that wheel because I had a couple of drinks, or I knew that I was too tired, or, I'm responsible for the injury that has now caused so much damage. How do you help someone through that kind of therapy, that kind of work with therapy?
Yeah, it's a really good question. So we can't create fake memories. We can't erase memories with EMDR, but EMDR does remove the toxicity or the dysfunction around some of the memories to say, like, let's say the person was texting and driving, right? And hit somebody, or maybe they themselves were in a single car and hurt somebody in their vehicle. So the guilt and shame around there may always be a little bit, right? But let's say instead of it being at a 9, maybe we can get it down to a 1.
Oh, wow.
Right?
Okay. Yeah.
Or maybe, right? I'm just saying every client's different. Every person's different. and EMDR won't take out, if there's like a shitty part to a situation, it's going to be shitty if it's factual, right?
Yeah, for sure.
It can't override fact or logic.
Right.
And we're not trying to do that, right? We're just trying to take away a little bit of suffering.
Understood. All right, great. Now, have you done any writing, or have you been on, have you gotten to the point where you've done some speaking about this? Are you an advocate for TBI in a formal setting?
I'm not yet. No. I know here in Colorado, we have the Brain Injury Alliance of Colorado, and that's a really big one. And I'm actually going to be on their podcast later this month.
Oh, cool. Congratulations. That's great.
So I'm super stoked to be on that, share my story and also inspiration with other people going through very similar in terms of TBIs too. But so I've not done anything formally. I do write a lot of blog posts, if that counts.
Yeah, that does
count. So that's on my website, but nothing like research or publications or anything on that level yet.
Well, I really appreciate how loving you are and how much you are an advocate of humans, and specifically humans who have had unfortunate experiences of trauma, which have led them to be in some ways either marginalized or fragmented in their capacity at some level, whether it be physically or cognitively. And it sounds like you're a great person for them to come have conversations with.
Yeah. Yeah. Thank you.
If someone wants to have a conversation with you or follow you or learn about you, where is it that they can find you?
Sure. So I'm on Instagram at revitalize_mental health, Facebook too, Revitalize Mental Health, website, revitalizementalhealth.com. You can submit a form on there, give me a call.
All right.
We can start from there. I'm only legally able to do therapy for people who reside in Colorado. So, we'd have to work out some logistic stuff if listeners are outside, but.
Okay, cool. And we will have that all in the show notes as well. Daniel, it's been a deep pleasure to have you here. Is there any questions you have for me or anything you want to leave the audience with? If there's one big thing you want to tell the audience, now would be a good time.
Yeah. So I think we're all going to have a levels or differing forms of adversity to show up throughout our lives. And we can use those experiences as foundations to really launch into new versions of ourselves or develop new perspectives to kind of take on the world and follow our passions.
Beautiful. I love that. And that's clearly what Daniel has done. And clearly he has become somebody who's super effective, super caring, super present, and very intelligent. And it's an opportunity for us to really meet somebody who has earned the stripes the hard way, like actually come from the ground up through his own traumatic brain injury. Daniel has become an exquisite clinician. And Daniel, thank you so much for joining us on the show today. You clearly are a healthy healer, and it's a gift to have a great conversation with you.
Thank you, Dr. Fred. Appreciate being here.
Absolutely. Bye for now. It's Dr. Fred. Hope you enjoyed it as much as I did. We'll catch you on the flip side. Bye for now.